Okay, good afternoon, hello, and welcome. It is Matthew Holt. You are now watching listening to on the podcast, or watching live, or watching after the fact, the THCB gang. Okay, great lineup of my regulars today, and a very special guest who has actually been on the gang before, so good fun. Who do we have today? Well, we still have the weird glitch where the video is cutting in and out for me on Zoom, where they still haven't seen fixed that, or maybe it's my fault. But lineup, myself, founder and publisher of the Health Club blog, as moderator, Jen Goldsack, CEO of the Digital Medical Society and international for 2 countries, Kim Bellard, regular writer and THC contributor, John Neptune from Suntra Modern Recovery, and also the podcast Is It Serious? Jennifer Benz, who we just discovered has a real job at Siegel Benz, and our special guest this week, former CEO of the Permanente group, both the overall federation and I believe the California and the East and the DC version. I couldn't quite remember what he ran. Robbie, who's now author. He was on when his new book Uncaring came out a few months back, and also runs the Fixing Healthcare podcast, which we know can't be a proper podcast because it spells healthcare one word, not two. Therefore, is not the right code. Needs to fix that part. All right. That's the most important debate in healthcare, of course. How many words in healthcare? But
clearly.
That will run and run. All right, fantastic. I will be flicking in and out of video while I figure out why the hell this thing doesn't work. I have 3 or 4 other people I regularly go on with on Zoom where this weird hallucination thing, like Max Headroom comes on. I don't know what is happening, but let's kick it off. Another week of intense craziness, and we've had, since some of you were on, quite a few conversations. I think Medicare Advantage we can't stop talking about because there's been a lot of stuff, not only the acquisitions in that space, but also a lot of government regulation and stuff to come. And then we've had more legislation or regulation from my favorite organization, the DEA, quote unquote, about drugs and telehealth. So there's a bunch of stuff to talk about, but let's kick it off. I will start with you, Jen Goldsack.
Well, great news this week, seeing Lilly slash the prices of insulin almost 70% across the board if you average it out. It was really disappointing not to see that go through with the budget at the end of the year with a big omnibus bill, that we weren't going to cap out-of-pocket prices. So the fact that that's come from industry is fantastic. And, insulin's always the example that I reference all the time when we talk about innovation, because it's 100 years old now, right? There was a little boy 101 years ago that got the first injection of insulin while he was in a bed in Toronto starving to death. And still, until now, 1 in 4 Americans with diabetes ration their insulin. So this is, I think, a really compelling story, a really important story. And I think it's one we need to look at closely and learn from. So, props where props are due. Really great to see that coming out from industry.
Excellent. I'm sure it'll happen to Humira any moment now. Maybe not. Kim.
Well, I was going to mention the Lilly thing too, but I'm a little bit more skeptical than she is. Reading the fine print.
Amazing.
It doesn't apply to all the forms of insulin. They're not making any promises about price increases. So I think it's a great PR move. I hope it benefits many patients. But I kind of think that, it's not as big a hit on Lilly's as people think it should be. So I'm reserving judgment about what long-term impact it's really going to have. It's a great PR move, hopefully a good humanitarian move, but their stock isn't hurting from this. So
I'm hoping for the latter, Kim. I really am.
All right. Jen. Other Jen.
Lots going on. I'm sure that you all have touched on the Secure 2.0 Act already that passed over the holidays, but we're seeing so many ripple effects from that in the employee benefits world. And then in talking with a lot of our clients over the last few weeks, I think there's going to be this big sorting of all of the vendors and point solutions, kind of who stays, who goes this year. And that's going to be really interesting, especially coming off of all the changes in the funding and everything that has happened in the last year. So I think it's going to be fascinating to watch what happens over the next several months as employers are trying to figure out what to cut and what to combine with their whole benefits world.
All right. That's going to be a big one, runs around. So how are employers going to buy both digital health and regular health? And also on the employer front, Humana got out of the employer. I mean, they weren't a big player, but they got out of employer, commercial benefits as a whole. So That's a world that's going to continue to change and may or may not have some impact. Every time I have Ian Morrison on this show, he claims that PBGH is about to do something, and I always go, yeah. Remember what you said in the 90s, how the employers never did anything. Yeah. JL, your world in particular has taken some big changes this week, so I suspect that will come up.
Sure. Yeah, I think we'll talk about that at length, and actually I'll leave that for my thing to look for toward the end. I'd say first, I'm still thinking about the Rock Health report about 80% adoption of consumer digital health, which I think is interesting. I haven't really spent a lot of time in the data, but I thought that was an interesting point that we've reached. I thought also what was interesting in the study was that audio only continues to be more widely used than video, which I think is something that doctors know as interacting with patients. You can get a lot just you're talking to somebody on the phone. But I think the data shows that people really can get a lot of good healthcare just talking and not using Zoom, which is great. I think one other point that I'd like to get a little meta on the Eli Lilly price cut. You may remember that when Elon Musk took over and decided to make, blow up the blue check system, they got trolled for like a whole day, and somebody actually came on as an Eli Lilly troll and talked about the price of insulin. And I believe that had an impact. And maybe at some point in the C-suite, somebody said, hey, we can't let that happen again. We need to be proactive here. So maybe Elon Musk taking over Twitter is part of what's allowed us to get to this lower price point.
Didn't the price go down, or the stock go down more when the trolls said they were going to do it than when they actually said it? Yeah, interesting. Well, we'll dive back into telehealth. I did note, speaking as an idiot who foolishly bought Teladoc on a dip, some numbers north from where it is now, that this didn't seem to help Teladoc's numbers, right? And I mean, a lot of. I had someone said to me, I forget who it was, someone said to me the worst thing that happened to the performing big telehealth company, independent telehealth companies, was the pandemic, because every other doctor in America realized that they could just use the phone, right, or FaceTime, or Doximity rolled out something for free, and it kind of killed Teladoc and Amwell and Doctor on Demand, all their business models a little bit. Anyway. Robbie, great to have you back on the show. You've been looking at a lot of stuff, not to mention what's been going on this program, but looking at other stuff. And I suspect you have a lot to comment on, but pick what you like. But I would suspect you have something to say about where we are heading with capitation, plus the Oak Street deal that happened since we last had you on just a few weeks ago. We've talked a lot about that and said a lot of other people, but there's probably more to come there. But I raised that. But you tell me what you want to talk about, and then we'll dive into a few of these topics.
Well, it's great to be on this show, Matthew. Thank you for having me back. In terms of the book on caring, by the way, all profits go to Doctors Without Borders. It's a group that I support highly and encourage everyone to support. They're doing amazing work around the globe right now. The biggest thing that I will point out, and I think it holds in a lot of areas, is how our minds fail to understand the exponential curve. So when people talk about ChatGPT, it's a toy. What you have to look at is what's it going to be like in 10 years if Moore's law holds and it doubles every 2 years and it's 30 times more powerful than today. And what's it going to be like in 20 years when it's 1,000 times more powerful? Same thing with the retail clinics. You and I engaged in a little conversation. This is not about a primary care play. These acquisitions of Oak Street, the acquisitions of One Medical. This is about taking over all of healthcare and recognizing, again, not what's happening now in 6 months and 12 months from now, but what's going to happen ultimately. And what's remarkable to me about it, as you know, I'm a major proponent that we need to move from fee-for-service to capitation, or we will never change healthcare, is that all of these retail clinics are moving very aggressively into Medicare Advantage for lots of reasons. There's a reasonable profitability there. It's an easy market to enter. You only have to do a single zip code. But I also think that it's going to be the movement into capitation. So don't look at what they're doing today. Don't even look at what they might be doing a year from now. Ask yourself, why are all these companies spending all of this money to acquire these pieces if they're not going to be making a big long-term play?
Absolutely. So I'll say three things we can go and cover the directions. First is the exponential change thing is fascinating about how people don't recognize it. So right now, if you look at the charts of the cost of energy and how energy is being produced, especially in Europe, I mean, Europe is basically, because partly forced there because of Putin and gas, is now almost about half renewable energy. It depends how you count nuclear, et cetera, et cetera. But I mean, we're going through this change very rapidly. You're seeing the early parts of that exponential curve happening with electric vehicles. I actually I ran past one of the first Rivian Amazon trucks, and then Amazon's going to move all their fleet. You're seeing that happen in other areas quickly. ChatGPT obviously is like the early part of that curve to sort of really commercialize this stuff. I'm always very unconvinced because, I think, Robbie, we had this conversation in 2009 or 8 in Washington, D.C. about how, Kaiser was going to spread, could potentially spread everywhere. And healthcare seems to, take this stuff in and spit it out and not let it happen. I'm always, curious about how it's going to happen and when we could really see it happen in healthcare, as we've been doing it a while. JL, you said you wanted to say something about ChatGPT. Why don't we talk about that for a second and then go to sort of Robbie's bigger point about healthcare change, and then we'll come into some other topics.
Sure, but I think Robbie's point about the exponential growth and how people don't think about ChatGPT properly. I think people are thinking more linearly. And I always like to share an anecdote because I've been having this debate with people for many years. My father was a physician. He was a pathologist. And for people who don't know, pathologists, maybe other than radiologists, are some of the most technologically advanced physicians in a hospital or in any healthcare system. A laboratory, my dad was a clinical lab guy, is almost a fully automated operation. So my dad was very much into technology, wrote code that people still use at the hospital that he used to work in. He used to write code in machine language. I mean, crazy stuff. I remember we were early adopters of Dragonsoft. So we used to use Dragonsoft in the house for transcriptions. And I just remember telling my dad, like, this is awful. This is horrible. Nobody will ever use this product. This is the worst thing in the world. This computer is so stupid, right? 20 years later, my wife, who is like not at all technologically advanced, does not type on her phone. All she does is voice recognition on the phone, and everybody's got an Alexa, and everybody is using some other kind of voice recognition technology. So I really do believe, like, if ChatGPT is here, where it's going to be, I heard somebody saying like that in 10 years, imagine a ChatGPT that is 1,000,000 times more effective, more powerful than what you're seeing now. I mean, I really do think we're moving in a direction where computers are going to be able to do many of the jobs that doctors do. And I don't know, the catalyst for this debate with somebody that I had was that ChatGPT had scored a 70% or a passing score on the medical board examination. And there are a lot of doctors saying that, the computers can never, take the place of doctors. But I was like, the computer is able to answer 70% of those questions. I've sat in those tests. Those tests are basically testing your ability to analyze patterns, make recommendations, and do a bunch of different things that doctors do. If ChatGPT can do that now, the 1.0 version of it, what does the version 10.0 of it look like? So I really do believe, and Vinod Khosla has trolled doctors for a decade with the statement that technology can replace 80% of doctors. Maybe in some functions we will see ChatGPT or its descendants doing a lot of what doctors do.
And if I could add that healthcare doubles in information every 72 days. Do we really believe that the human mind can keep up with this technology at some point? Not now, not the next generation, but is it 10 years from now? Let's think back 20 years ago to 2000. How much has changed in 20 years in medicine? Not very much. How much is going to change in technology over the next 20 years? Massive. So that's where I think the big difference will be.
100%. And Robert, to your point, and JL, to the data that you just shared, right? If like a ChatGPT can get 70% on medical boards, then there's something wrong with the exam, right? We're not actually training or testing people for the skills that we need physicians to have in a technology powered era, right? We need to actually think about the changing role of a physician and how actually what are the skills that technology can't have, and we train them and we equip them and we position them for success there. And then that's how we overcome the clinician crisis. And it's not going to happen overnight, but I mean, it's clearly the wrong test in this day and age. If those are the kinds of scores we're getting.
And there's still not a single medical school that has a course in artificial intelligence for its students in the first 2 years.
Fun fact, There is a new 4-year digital health track at Rocky Vista University. It's a DO school. They've got a couple of campuses out in the Midwest. They have a 4-year digital health track, and I know for a fact they're teaching AI in the first 2 years of that, and it's impressive. And the fact that it's the one and it's the stat that I'm excited to share, I think, Robert, to your point, is the problem.
Kim will tell you why the fact that there is a DO school is a problem, right? Last week, a couple of weeks ago, you were saying the fact that we have DOs and MDs doesn't even make, it's another history.
It doesn't make sense that we have got both tracks of physicians, because that's rooted in a 100-year tradition. They're trained the same way, they practice the same way. Why are there 2 tracks? I mean, it doesn't serve any purpose other than the people that do the schools and the regulatory system.
So Matthew, if I
with allopaths.
I'm still selling the snake oil. That's that works fine.
So Matthew, if I could throw one thing out to the group,
yeah,
because it's part of why you invited me here today, is capitation. And I wanted to emphasize that there's 2 capitations, and I have not heard people talk about this in the past. You can capitate at the delivery system level, or you can capitate at the insurance level. Capitating at an insurance level is not capitation. And I say that because doctors are then going to be paid, hospitals will be paid fee for service. And the only way an insurance company capitated can maintain profitability is by limiting care, prior authorization, narrow networks, all sorts of problems that become difficult for the patient. When I talk about capitation, I'm talking about capitation at the delivery system level. And that's really hard to do. And there are only a few models that are there. But when I was the CEO in Kaiser Permanente, we were able to get 20% higher quality according to NCQA, 20% better service according to JD Power Associates, and 15% lower cost. And you're not seeing that anywhere. And so talking about capitation, again, is what exists today, is not talking about capitation. Talking about capitation in a competing way with large groups, all taking the same dollars, with the same kind of measurements of outcomes. That's what we're talking about. And that's where I believe the transformation of medicine is going to happen. Whether it's led by clinicians or the retail world, I don't know. But I'd at least like to throw that out to the group to see what the group thinks and thinks if it's possible to get to capitation at the delivery system level across our nation.
So let me twist that a slightly different way, right? Because there is some data. Humana keeps on putting out this report every year about, which I wrote about, which sort of compares people within their MA group, their Medicare Advantage group, as to whether they go to a fee-for-service doctor with light risk sharing or go to the Oak Streets of the world who are capitated, right? And their basic answer at the moment is that the cost isn't that different between those 2 groups, but they say the quality is a bit better on the capitated side. Your former colleague, boss George Halverson, writes on THCB all the time, talking about how Medicare Advantage, especially with special need program groups, does a better job on quality and on cost. There's a lot of debate, as we discussed, about cost and risk sharing and risk adjustment, et cetera, et cetera. But I guess my question for you and the group is, are we seeing that really be the plan of the big organizations who are currently buying up doctors? So you take Optum, you take CBS, you take Humana with their deals with ChenMed and others, you take who am I missing? Somebody. Who else bought a sorry, Amazon, right? Do you see what the path is to get those largely fee-for-service groups that have been buying, with the exception of the Oak Streets and Ioras? Do you see a pathway to getting the rest of Medicare Advantage into real capitated delivery system arrangements, let alone the commercial folks who mostly are in light PPOs, the ones who aren't signed up for Kaiser or Geisinger? So that's my question to the group. But why don't you start, Robbie, where you think we are in that transformation and why you think it's actually going to happen?
I think we're early again in the exponential curve. I want to point out that Optum employs, these are not the network physicians, they employ 60,000 physicians. If you do the math, I like to have, a doctor for every 500 people in a population. That's a variety of specialties. That means that they can take care of, theoretically, they don't have the right balance yet, 30 million people, which is 10% of the American insured population. Amazon is trailing the most, They've only made the smallest step in the acquisition of One Medical. You can be sure they're going to expand One Medical, and then I think they're going to take in specialists. CVS is somewhere in the middle. So my answer is yes, I think they're going to get there. They're not going to get there in the next 1 or 2 or 3 years, but I think they're going to get there over the next decade. And I think Walmart combined with United Health is the group that's right now most likely to get there the quickest.
I left out Walgreens, of course, with their acquisition of
Well, they're different because they're really
Village.
pharmacy-based primary care. I think the United is going way beyond that as they're trying to be able to manage the totality of the healthcare dollar. And that's the other thing that I'm going to say. You know, as we know, primary care is 6% of the healthcare dollar. The money's in the other 94%, or you can 65%, because some of it's going to be profit and other things. And it's going to be who can be able to gather that in to be able to create the quality and lower the cost. And I really believe it's where the retailers are going to go. And I think if the current healthcare incumbents sit back and say, oh, they'll never get there. Who wants to get their care from a retail clinic or whatever it's going to be? By the time it happens, they are going to be ruining the day they didn't do something, and they're never going to catch up. They'll be employees for the rest of their life.
So three concerns about capitation that I think haven't really progressed in the last 30 years. The first is, do you have comparable populations? You know, if provider group A has a much healthier population than provider group B, and they're getting the same capitation, then one group's getting screwed. The second is leakage. Like, so what's not in the cap? What is more incentive for them to go outside the cap for than to keep it within the cap? And the third is, what do you do with the real outlier patients? You know, there are some, you know, train wrecks that no capitation is going to be adequately funded for. So you got to address all three of those if capitation is going to be the way forward. And, you know, we still don't really know how to evaluate, you know, what the right ways to do these things are.
Well, let me ask that about, because, you know, who has more experience with provider level capitation than Kaiser Permanente? You mentioned the 6% of spending. So, Robbie, what was the spending percentage for Kaiser in primary care versus everything else? And then, you know, how did Kaiser, which, you know, has great, well done, history going back to 1932 or whatever it was, right? has some previous, as they say in England, about that. How did Kaiser manage those three issues that Kim talked about, especially the outliers?
So I would say the primary care dollars were probably in the 8 to 10% range. That probably should have been in the 12% range. Primary care physicians were paid about 20% more than the community. The overall physician dollars are matched because it's a not-for-profit health plan, so it has to be matched. So specialists will earn a little bit less, but they were not unhappy about that because of all the support that was there. I think the points that are made about the capitation questions are very significant. In a risk-adjusted model, theoretically, you take them out. At the individual level, yes, they do pop up, but when you take it across a big number, remember, we're talking about 12 million people, the outliers drop out. There are people who are going to need transplants, and that's just the cost of doing business. I think the hard part is for the small groups that are out there, ones that are trying to form. But the bigger problem in capitation is the transition. So if you take a hospital and you say, okay, we don't really need to have 1,000 beds. We could get by with 500 beds. You'll pay us for 750 because that's the deal that's going to be made, rather than you'll make money, we'll make money. But getting from 1,000 patient down to 750, even to say nothing of 500, is a long time period, and people go bankrupt. And that's why no one has really done it, unless, as you say, you have the Kaiser Permanentes with Sidney Garfield in the desert. You have the Mayo brothers sitting there somewhere in Minnesota. You have all these stories of people who did it 50, 60, 70 years ago when the cost of healthcare was so much lower. I think those are the ones who are able to do it. The real question is, how is it going to happen? And again, I'll go back to why I think the retail clinics could play a big part, because the fact that they're going to be new entrants into the marketplace. They're not going to contract with every hospital. They're not going to contract with every specialist. I think we probably could get by with half the hospitals we have and probably no more than the specialists we have, despite the growth that's going to come. We just need about twice as many primary care clinics, physicians, in order to provide that care that's there. And I'll make one other point. If you look at the hospital days that we had when I was the CEO, it was half of the national average. And we took the numbers and we looked at, we said, how did we get down to half? Half of the half is prevention. Half of the half was we had fewer heart attacks, strokes. We didn't have a different population. They stayed in Kaiser Permanente on average for 17 years, were able to prevent the diseases from happening. And the other half was sitting in more efficient hospital operations, because in a capitated system, an efficient system of care does better. We had 70% outpatient total joints. The community around us was sitting at 5% or 10%. And why did we do it? Because we got better outcomes at lower costs, and it fitted with the model. Capitation, to me, aligns incentives. I just can't see how people don't recognize that. You have an incentive for prevention. You have an incentive to avoid complications from chronic disease. You have an incentive to use the tools of technology that work, not a whole lot of operative robots that have never been shown to have any advantage. You just go down all the list of things that as a patient, what do you want? We got down to access something like 70 or 80% within 1 or 2 days. Why did we do that? Because in a capitated system, there's no disadvantage to being able to provide timely access. It's not a cost. It's the efficiency of not having to have people waiting while you have to manage them in the wait period. It's less expensive. So I see all the pieces aligning within that system. The hard part to the question that was raised in the comment before was getting a system that is truly capitated to a delivery system is very tricky. Getting from fee-for-service there, getting across that bridge. But I saw some heads nodding before about that thought. I'd love to hear from the other people sitting on the call today, on the panel today.
So can I go to Jen and Jen, either which way you start? But I think there are 2 points there, right? One is, are we seeing the models being developed in the digital health, et cetera, new world to actually start doing this that will take over, as Robbie suggested? And Jen Benz, are we seeing we're kind of seeing Medicare Advantage getting somewhere? What about employers in terms of caring enough about this stuff? So whichever one of you wants to start, I think both of you have got two angles on this.
Well, I actually had a question before getting into that. And of course, a siren in the background now too. But you said that we have enough specialists, but we need double the primary care physicians. So where are we going to get double the primary care physicians? Isn't there already a shortage?
So this is a great point. And again, I listen to this show every week. And so I always have comments I want to make. This is a great opportunity to do so. So that, thank you. There were 1,000 medical school graduates last year who did not get a residency. There are not enough residencies in the United States for all the people who are becoming doctors every year. And that number is not new last year. It's been true for a long time. The federal government could increase funding for primary care residency programs. I wrote a Forbes piece about calculating the cost. It would be, I think, less than 1/10 of 1% of the Medicare expenses today, because it's paid by that same federal government funding. And we could produce, again, not in any 1 year, but over the course of 3 to 5 years, we could start to increase that number significantly. We'd have to change things about the way we pay doctors, because one of the disincentives right now is that primary care earns so much less. You look at the objective data, add 10 primary care physicians to a community, and you increase longevity 2.5 times, adding 10 specialists, and we still train lots of specialists. Why do we do that? 2 reasons. It's a lot more money for the hospitals because the Medicare funding comes through the hospitals. And number 2, in the culture of medicine, it's thought to be elevated and higher esteem. But I think we need to train them differently. They need to understand how to use ChatGPT, how to use a phone, how to use telemedicine, how to interact with families, how to do prevention. We got a lot of different ways to train people. The system, I just think, is broken underneath it. But we could definitely have them, 5 to 10 years, we could actually train enough primary care doctors to take care of the population that we have and the one that will be aging, unfortunately, across the next decade of time.
Yeah. And so it's really tough because I listen to this and I want to stand on my chair and sort of say, yes, that's exactly right. I think you got to the heart of the matter when you talked about the transition period. And it's actually that activation energy that makes all of this so challenging. So many of the ways where sort of capital is tied up within the industry right now, there's a reason the last time we saw full-scale change like this was 60, 70 years ago, right? Because just the sunk costs and the sort of financial debt, quite literally, we carry from all of those robots that you mentioned that we've bought, and we have to keep using them. Otherwise, what are we going to do? And so, as I always end up saying when Matthew invites me on, I think this is where we do have to look to these newcomers to the market who aren't encumbered by these sort of sunk costs, these brick and mortar environments, who aren't sort of, what was the data that actually came out in the last few days? The margins over the last quarter are now at the median margin for a healthcare system is now -1% as opposed to -7% where it was, I think, 2 quarters ago. Still a negative margin, right? So you're hanging on to that fee for service revenue with your teeth where you can get it. And so this is where I think it is those new incumbents, it is those virtual first care providers. But I also think that part of that is not just, look, we're going to build care around the patient and not the clinic. I also think it does come with a fundamental, and this is where, it just sounds like I'm giving a lecture, but it's that reimagination of the value chain, right? That actually you have to start getting paid for keeping people healthy and out of the hospital, instead of standing in the hospital waiting for them to turn up sick and expensive so you can extract your fee for service. The reason I'm stuttering a bit is I think virtual first care, I think those retail sort of driven care providers are going to take us a very long way, especially ones like CVS Health that have all of that data from Aetna, especially Walgreens, Walmart. 1 in 2 Americans walks in, I've said this before, I know I have, 1 in 2 Americans walk into a Walmart every single week. That's enormous reach. And many of those folks don't have access, mostly because we've closed their local hospitals already, to other sorts of care. So I think if we can make inroads there, maybe that's the incentive we need to get to a PE managed healthcare system to say we're gonna go through short-term pain to get that long-term gain. Doesn't solve the 5 to 10 year gap on primary care providers. But Jen, go ahead.
Yeah, I think that all makes sense. And I think especially the trust of people where they live is so key. And that can be virtual, but people want to have a lot of confidence in the organizations that are providing that care. I think it's going to be fascinating on the employer side. There's a lot of experimentation with centers of excellence models and requiring people to get second opinions and things like that, but not a lot that have gone, fully in this direction. Employers offer Kaiser, of course, as a choice where Kaiser has presence, and they do a good job, but that there aren't that many that have fully put everybody into that, just because there's so much of this demand for choice in healthcare still in the employer market. And one of the things I think employers are most worried about from a change management standpoint is reducing people's choice, with whether it's reducing their choice of doctors or reducing their choice of plans. So even in cases where employers might have just a handful of plans now, I remember 15 years ago, employers would have 8 or 9 health plans to choose from at different points. Now, most only have a handful of plans to choose from, but then they don't want to restrict people's choice within those plans. So, we have these PPO plans where people can basically go to any doctor they want to, and, without referrals. So there's no real management or pushing people down quality. And I think the big challenge is, how do we really restrict people's choice? And when are the tools going to be good enough, or when is the experience going to be good enough that people just say, oh yeah, just tell me what to do, because I don't actually want to figure this out on my own. Nobody wants to figure it out on their own. They're kind of forced to now.
Well, we're talking cultural. Sorry, go ahead, Kim.
So we were talking about ChatGPT, and I think the technology is going to be ready way before the rest of us are. I mean, the two barriers that we are not at all ready for are the culture. People don't really know how they're going to use this stuff and don't really have it integrated into how they do things. And second, the rules and regulations are woefully inadequate. Like so we all believe that, AI in some form can act as some sort of triage, at least, if not become a fully doctor. But how would you regulate it? What would you want them to do? What wouldn't you want them to do? How would you define that? Who's going to oversee it? these are real questions that are coming on us at 100 miles an hour, and we are still looking backwards at how we did things 100 years ago, and it's going to crash.
So to talk about looking backwards, and I know there are reasons for this, and you're now about to hear me talk about my kids again, which I know I do every time I come on this, but because they live in Marin County and therefore have ADHD, right? They've just and Jael, I wanted to get you in on this. The regulation, we're talking about regulations right now. People make money getting paid fee for service. I've had a couple of venture deals cross my desk recently, which were essentially saying, how can we cannibalize and increase a fee for service either in physical therapy or some other area where I can use the current Medicare and commercial fee schedules for fee for service, do something a bit better, more efficiently, take a bit more of the margin, and replace old world hospital systems. The same way you could argue that maybe the initial cover the retail clinics is going to replace some of the old world primary care clinics, but not actually fundamentally change how we do this. Meanwhile, regulations on things like telehealth seem to be, and Jen, you and JL must have comments on this, seem to be winding back, right? I know we had quote unquote scandal about overuse of ADHD medication from Cerebral and others, et cetera. There's right now a massive shortage because so many more people got diagnosed during the pandemic, and if you're trying to get this stuff for your kids or yourself, it's in really short supply. And now, DEA, my least favorite government organization, is winding back some of those pandemic regulations and looking like they're going to make it harder to get some of this stuff, harder to get, and even harder to get some of that MAT medication, right, that Jael that you prescribe. So I'd love to hear you two talk a bit about that in specific and try and sort of extrapolate that to how you think Kim's point of regulation is going to help us, because my opinion is that we don't see regulations level the playing field and make it easier for these new entrants to come in and save money, and it's going to be tough to displace the incumbents. Anyway, Jael, Jen, somebody shoot.
I mean, I can make the first comment. I'm a DEA license holder, so I got that email from the DEA saying that they are considering making changes, right? And the changes that they're essentially considering making is that for anybody to get access to a controlled medication other than buprenorphine, you would have to be seen in person first, right? So essentially reapplication of the Ryan Haight framework, and that even for people who have been on a medication like buprenorphine for a period of time, who have never been seen before, they would have to be seen in person to continue beyond 30 days, right? Which are both very regressive kind of proposals, especially given where we've been during the pandemic and the pandemic health emergency exemptions. I think the key thing I'd say is that, number one, it's a proposed rule, so we have 30 days to comment on it. I think the Biden administration and many other progressive-looking people have argued that what the DEA is proposing is regressive, is going to hurt people, particularly around the opioid epidemic, which has not gone away. And by making it harder for people to access buprenorphine and other life-saving medications, you're making things better and not you're making things worse and not better. And I think the point has always been that buprenorphine is really not an abused substance. People actually, most of the addicts that I've worked with actually use it in a very strategic way to manage their addiction, and often do it in, not in a professional way, but are doing it for the right reasons. And obviously physicians should be helping them to do that even more. So I think, again, we're in a comment period. I think there's going to be a lot of pushback. I've seen a number of elected officials have already weighed in on this. So I think that's going to change. I think they will push back. I think actually Biden is going to make a big stand on this, because I think it's got a lot of symbolism to voters that he's trying to connect with, white working class voters, people who live in rural areas. I think the opioid epidemic is very important to them. I think Biden's trying to connect. I think he's going to make a stand on that. But at the end of the day, you got to remember, DEA is a law enforcement, has as much of a law enforcement function as it does a public health function. Matthew, we talked about this on LinkedIn quite a bit in a whole series of discussions. You just got to remember, they see controlled drugs being diverted, being used inappropriately, people dying as a result of inappropriate prescription. And I think the DEA's their plan, or their reason, their raison d'etre, is to prevent these kind of things. And I think as a result, they're trying to close the door, make it harder to access these medications in that role. And I think it's going to take other people who don't have that law enforcement first view to push back on what they're proposing. But it's a very fluid situation, and it'll be interesting to see what evolves out of the 30-day comment period.
Jen, you guys, I assume, have got, commenting, and I know your colleagues at ATA have actually come out explicitly about this, but where is DIME, organizationally on this? And given the number of virtual first clinics who are doing mental health, and given the importance of some of these medications to mental health, and that explosion in the industry, both good and bad, over the last 3 years, not to mention the explosion in the number of people who need it that happened over the pandemic. Where do you think, where are you guys?
Well, we'll be commenting on this too. And I think this comes back to a sort of trope we're seeing around how we're trying to regulate telehealth, if you like, which is it's all being done with a set of assumptions and not with any data whatsoever, right? This idea of more fraud, waste, and abuse, absolutely unjustified. This idea of unnecessary care, like we at DIME did a study with Johns Hopkins and actually showed that it reduced, like if your index visit is a telehealth visit, it actually reduces downstream utilization for chronic disease. I think that there's just, we can't make these decisions in a vacuum from data, and data is emerging. And in fairness, for telehealth providers and virtual first care providers, they're working very hard to amass that data. But the reality is, and Matthew, this goes back to your back surgery sort of stories, we just don't treat regular care delivery like this, right? How do you know that I'm going to say something about physicians that I'm going to say to be flippant, so I preface it. How do you know the guy sitting in a clinic with the, shingle above the door isn't, pushing his drugs on junkies for, and I'm saying words that are very inflammatory because I'm trying to make a point, right? This is an illness. We do not have enough mental health care providers. There is a bolus of innovators who are trying to do things differently and address this issue in a way that's arguably more evidence-based than what is demanded in a brick and mortar facility. So why are we trying to stamp this out? And JL, I like your point about the two hats that DEA has to wear, law enforcement, but also public health agency, right? And so it's the public health isn't just minimizing harm, it's doing that, and it's promoting good health. And I fail to see how any of this logic makes sense. So I think we all have to step up. And I think, remember, the whole purpose of a 30-day comment period, every single one of us on this call could write our own comment. Every single person listening in could write a comment if they feel compelled to do so. And it's the law that it has to be read. So, strongly advise anyone who's got an opinion and feels strongly about this, take advantage of the next 30 days and let's not hope that the final rule is where we need it to be.
Yeah, I'll be both commenting and writing to my MP. I shouldn't have an MP, right? Representative JL.
Right, and again, I think so much of how you think about the DEA's proposed rules comes down to the mental framework that you have. I think for many people in medicine, for many years, and probably continuing on, telehealth is viewed as less perfect than perfect in-person healthcare that's happening, right? So it's like you can have the perfect visit in person with the healthcare provider, or the imperfect thing, which is this camera-based video thing that we don't think is as good for X, Y, and Z reasons. I think what a lot of people forget is that especially in addiction, for many people, like they don't even have this not so good, they don't have this perfect option anywhere, right? The perfect option doesn't exist because there's no perfect doctors where they live, or there's no hospital where they live, or they don't have any money, right? So I think that the frame has to be translated to say, hey, listen, there is perfect, and we try to aspire to perfection. But for many people, the option is going to be nothing if we move in this direction, and if we restrict care and we make it harder to access care. We know that 100,000 people died of drug overdoses last year. It'll probably be worse this year. We need to stem that. Yes, maybe there's some diversion, maybe there's some abuse, maybe there's some bad things that are happening by opening up the aperture and making it easier for people to access these medications. But there's a cost as well to doing nothing, and a cost as well to not embracing the imperfect solution as opposed to the perfect solution. And again, those are themes that I think you've been hearing from people who oppose what the DEA is proposing now, and hopefully that makes its way in this comment period and thereafter to the politicians, who can then say, hey, listen, DEA, you really need to back off from this and try another approach.
So Robbie, you know, when you were at Permanente and Kaiser brought in a whole bunch of, you know, for then state of the art, we could discuss Epic and all that stuff, but for then state of the art technology, started doing a lot of, you know, remote visits, started using technology to treat this stuff. Obviously, you know, it's kind of hitting the mainstream 10 plus, maybe more than 10 plus years later now. But regulation, as JL and Jen are pointing out, is a big kind of impediment and tricky piece there, not to mention, you know, ways that the payment's happening. Wind us forward. How do you think that this kind of regulation, and how do you think this kind of you know, lack of certainty to new innovations is going to impact the wider transition to capitation you've been talking about? Because you kind of lived this already once, and now it's got to happen in the real world, as it were. Not that Kaiser is in the real world, but you get what I'm saying.
So I think this gets back, I think that Kim made the comment earlier about how we're looking in the rearview mirror, not looking ahead of us. Telemedicine and in-person visits are no different. I mean, there are things you have to do. You have to stick a knife or a needle into someone. Occasionally you have to do a physical exam. The issue on prescribing should be, can someone prescribe a medication that is dangerous and never see the patient again? Whether it's in person or telemedicine, it doesn't matter. The issue really should be, is there continuity of care for difficult and dangerous medications? And you can do that virtually as well as in person. There's nothing more problematic about a telemedicine visit with a physician that you know than it is sitting in an office. It can be good, bad, or indifferent. It shouldn't change. It gets back to the same issue with ChatGPT. You know, we think of the tools as apps, and apps are algorithmically driven or human driven. They can be regulated by who creates the app, who creates the flow of decision-making trees and other pieces that will be sitting there. ChatGPT, you can't regulate. I mean, you can say it's illegal. You can throw it out along with TikTok, but you can't. Once it's there, you can ask any questions. What people don't understand is that the limiting factor for most people today, well, there are a couple of limiting factors. The data only goes to 2021, and there's some other pieces there, but that'll be solved very, very quickly. It's asking the right questions. Once you understand the right questions, you can become your own doctor using the technology that exists. So that's not an app that has to be approved by the FDA. So we have this notion in our mind of how to approach that technology that is so outdated. It's 50 years old. It doesn't really relate to the technology that's here right now. But you're absolutely right, Matthew. You know, 7 years ago, I wrote for Health Affairs. At that time, we were doing 12 million virtual visits, 1 million of which were through video at the particular time. We were bringing specialists into the primary care office using video to be able to see patients who had a new complaint, to be able to resolve the problem without seeing the specialist and having to wait a week. We're doing 70% of dermatology with digital images. You know, you couldn't do it for certain cancers, but for rashes and other things, you could do it. This is not a problem. And for us, it wasn't a problem because we were capitated. So we could look at what's going to be best for the patients and how to deliver it most effectively. I think the biggest issue is not going to be the regulatory, which is really problematic right now. It's going to be the economic, because so many of these things won't have a clear way to drive up revenue, to bring in venture capital. That's the point you made earlier, Matthew, that I can take a problem that's not done very well today, whether it's women's health, whether it's mental health, whether it's all sorts of areas, whether it's a complex and rare disease, and I can develop a pretty good system to be able to provide better care and charge for it, get someone to pay for it, and make a profit. The real question is, can I redo the whole system in a way that I get better collaboration, better cooperation, bring in new technology, lower costs, and still make a sufficient income to drive it if I'm a venture capitalist or private equity? And today the answer is no. And we have to make that answer yes from my viewpoint, Matthew.
So how do we get to yes? I'm going to assume that Medicare Advantage and those Medicare Advantage plans who are buying into medical groups and perhaps spreading them is part of the answer. I'm going to assume, Jen, that employers are part of the answer, maybe question mark. I mean, maybe even consumers by choice. So Kim and Jen were both talking about choice and people not being willing to, you know, wanting that PPO because they're, for whatever reason, you know, the notion of going to a Kaiser or going to a capitated group is a struggle. How do we get to yes so that we're not having the same, essentially this is the same conversation we had in 1990 or 2000, now we're still struggling, we're still at a very low share of the overall market being in those sort of real capitated groups.
Medicare Advantage is first.
Yeah.
Next is going to be self-funded businesses. Because when someone goes to a self-funded business, right now, there are not enough people to do the jobs. And right now, there's a lot of issues always for a business. But as the economics become more problematic, if a company comes in and can deliver high quality, guarantee easy access, bring in the most advanced technology, and do it at a guaranteed price to that company, I think the companies are going to start signing up to make it available. How they're exactly going to price it for their employees is a different question. But it won't, again, it's not going to happen this year or next year, but 5 years from now, it wouldn't surprise me if you saw an Amazon taking the product that it developed across that time period, the relationships it has with self-funded businesses, and essentially saying, we'll do everything for you. I just had a chance to speak to a big TPA conference, third-party administrators, and I said, if you guys don't convince the companies that you can make this transition happen, you're going to disappear. Because once these big retailers come in, they're not going to need you guys. They're going to be able to figure out how to do it themselves. And I think that time period, this disruptive moment, the history of disruptive change, it takes 20 to 30 years to come about. But once it starts happening on that exponential curve, it happens real fast. We're not there yet, but I think we will get there.
So Jen, I'm going to come to you on this. What are you hearing when, how much, I mean, when we've had the last 5 years of all your clients offering, massaging and infertility benefits, and whatever stuff that, is like enhancements to get people to come to work there. And now we're talking about fundamental change in the way they buy and get their employees to have healthcare. Mm-hmm. Is Robbie right? 2 years, 5 years? Never.
I don't know. It might be quite a ways out there. It takes a long time to get employers to make big, huge moves like that. And we've seen versions of it, like with the exchanges. And for a little while, we were really excited, like, oh, everyone's going to do a defined contribution for healthcare and put people into these big exchanges. And there was a bit of momentum, and then that didn't really fundamentally change the whole system. So I don't know. It's going to take a while. Someone's going to have to get it tested and really show that. I don't see, I have the view of clients who and companies who, view their healthcare benefits and their employee benefits as part of what makes them a great employer. So I think that's not the group that's going to start probably a lot of these things. The ones that are looking at it from the efficiency lens, from the cost containment lens, that's where some of those big movements will start. But that's kind of what a lot of people thought about the exchanges, that, oh, everyone is going to follow. And we didn't see that. We didn't see that happen. So we'll see.
There's a
no predictions from me.
There's a culture piece here too, right? Which is for whatever reason, I remember, God, one of the very first talks I ever gave, 1993, 94, where I was at a Rotary group when I was from the Institute for the Future. And I went out and gave this talk about, comparative medicine, whatever. And a guy came up and said, he was a small employer, and he said, what kind of health plan, can I buy, blah, blah, blah. And he's asking for health plan purchase advice, which I knew nothing about. But he said to me, it's fine for my people to be in Kaiser, but I want the better plan. I went, we have this culture thing where, that stuff over there is not freedom of choice, and I don't have the very best doctors in the network. And we can spout, Robbie, you and George Alvis and others can spout data the whole time about how it's better. Somehow, culturally, we've got to cross the bridge to make people believe that, Iora delivers better care than random. And you've told this story about your father and his vaccinations over the years, right? We don't culturally have this idea that, care is better in kind of organized systems where the whole person is looked at. And I don't know how that to me is decades more for us to get there. Maybe I'm.
Well, Matthew, let me point out, in the time that I was in the CEO role, we went from a market share of 34% to 46%. That's almost 1 in 2 people. It's hard to argue. Yes, there might be still the other half, but a market share of 46% outside of maybe Coke and Pepsi, it's hard to think of very businesses that have that type of market share that's there. I think the biggest challenge, and you and I have had this conversation before, why has Kaiser Permanente not done so well across the country? Because it hasn't really done the same capitated at the delivery system model. It's basically gone in there. It didn't have enough patients on day one, and most of it was fee for service with the community. And that's the challenge. People, if you're contracting with people whose basic business is fee for service, you're going to get the same care they provide in the fee for service world. You're not going to get the improvements that are there. And so to that point, I probably agree that it may be longer than we've talked about, not because I think the employers would go for it if it were done well, but getting it to be done well, I think that will take a while. And again, that's why I see someone like a retail clinic who's coming in, the point was made earlier, who doesn't have any legacy systems in place, or very few of them sitting in place. They might be able to speed the clock up quite a bit. We'll have to see.
All right, so we're almost at the end of our hour together. It's been a great conversation. Let's have a quick go around and see what people are thinking about, looking at, and watching over the next couple of weeks that we should all be paying attention to. There were some things we didn't get to, including we didn't talk much about, how is Medicare Advantage itself going to be changed by the audits that are going on around risk adjustment. Risk adjustment came up, coincidentally, and we know we no need to make it work. We're not sure it does work yet, but we'll go from there. So why don't we start going around and seeing what people are looking at for the next little bit? We'll start with you, Kim.
Well, I'm waiting to hear what the Texas judge does with the abortion pill case. It's frightening that this may be a worse decision than Dobbs, because most abortions nowadays are with the abortion drugs. And if judges can start telling the FDA what drugs should or shouldn't be out there based on his political views, that's a disaster for us all.
Talk about retrospective, backward-looking regulation. Oh my God, absolutely. All right, I'm sure Jen and Jen have got no opinions about that. But Jen Benz, what are you looking at?
Well, also on the topic of women's health, I didn't mention this at the start, but I'm sure everyone saw the data that came out a couple of weeks ago about how much teenage girls are just really, really struggling right now. And that needs so much attention. It needs so much attention because of the mental health implications of that. I mean, just all around. And I think a big contributing factor is social media, of course, and how much pressure. And when you were talking about ChatGPT, it made me think about the filters, like the filters that are on all the social media when they came out. They were totally harmless. Oh, this is fun. Put a little bunny ears on or whatever. And now those filters are so good that you have no idea when someone actually is using them or not. And that's really, really damaging for folks. So that mental health combined with, where we do and don't regulate technology, I think is a really important topic to watch.
Yeah, as a father of an 11-year-old girl, I'm seeing a lot of that. And I'm seeing a lot of, where the hell to find the bloody Adderall that
yeah.
is somehow gone missing from the pharmacy chains. All right, JL.
So, I'm very interested in the venture investing environment and sort of, what's going on with fundraising for digital health companies. As we mentioned, many digital health companies are facing what could be an existential crisis around these DEA rule changes. I do think that, really creative companies will figure out how to include an in-person component if they have to. But I do think, remember, many companies raised huge rounds at the beginning of the pandemic, 2020, 2021, and many organizations are coming to the end of their 18 to 24 month runway from their last raise. And it'll be very interesting to see, given this uncertainty, how many companies are able to raise and further evolve their business, and how many companies are going to sort of go the mind strong way and wind down and shut down and blow up because they just weren't able to find a sustainable model for the future in light of this changing regulatory environment.
Yeah, there's clearly a few companies who perhaps bought too many buses and not enough, spent enough money to build a hospital care. Not to mention anybody's names, but you've seen a lot of layoffs across industry in tech and digital health, and also in other tech. And some of the layoffs have made companies very profitable. Salesforce had a banging quarter. Now it got rid of a lot of people. Jen G.
We've talked a lot at the intersection of sort of, healthcare and regulation today, and I think there's no getting away from that in some ways. We're trying to flip the script a little bit in how we talk about this at Dime and sort of across our portfolio of work and all of the partners that we have in the industry, which is we've got to start looking at regulatory strategy as actually just being an essential component of good business strategy. So we were proud to host FDA just yesterday, actually at a launch event, when we came up with a whole sort of regulatory pathways tool. Now, specifically for digital products, right? Not digitally enabled care. But if we're thinking about things like, algorithms and AI tools that can help extend the physician, there's been a lot of railing against, perceived expansion in FDA oversight of AI, as opposed to, they make a medical claim and thus they are a medical device and thus they will be regulated as such, right? But trying to demystify that a little bit, because, JL, to your point, what is one thing that businesses can't withstand? And that's uncertainty. And there are actually very, very good regulations already around digital health products. We just need to get everyone into the mindset of not trying to do gymnastics to avoid them, and to actually think about the fact that they can be used to differentiate yourself in a tough market.
Yeah, I'm always a little suspicious about, especially the digital therapeutics group who seem to be heading down the path of, can we make this thing look like a drug from 1975 or 2005, rather than make it something that, as Robbie said earlier, can be evaluated as under a capitated system, something that either works or doesn't work as a piece of technology, especially to replace human capital. So hopefully people will be thinking more about that as you think about, FDA regulation, and we shall see. All right, Robbie, you get the final word as to what you're looking at, what you're forecasting next few weeks / next few years.
Well, I'd say what I'm looking at is I got 2 phone calls 2 days ago from medical groups that do a lot of Medicare Advantage. They take care of the very sick people, the ones in the poor socioeconomic areas, people with mental health issues and other issues. And they just ran the numbers off of the new Medicare allocation, which theoretically was going to go down 2%. But both of them said when they run the numbers, one was going to go down 12% and one 17%. And they're going to face an existential crisis and maybe not be able to serve the poorest and sickest of all the communities with the dollars that are there. So I'm going to be very interested to see what Medicare does about this. We've debated Medicare Advantage on your show lots of times, but there certainly is a population that's not served at all except through those programs. And I'm very worried that if something is not done to correct the financing, that we're going to actually really harm people who are those greatest in need. Long term, I think that we are at an inflection point. I always combine, I teach in the business school at Stanford, so I combine the economics with the medical. I think our country is at an economic inflection point. I think we're at a medicine inflection point. I think there's tremendous opportunity with technology, with capitation, with new entrants, with change. And I also have a fear that we're going to move too slow or not at all. And a true crisis is going to occur. And I'm someone who likes to prevent crises, not see them happen. But we'll have to see whether that's the case. And thank you for having me today, Matthew. It's been a lot of fun.
All right. Certainly a pleasure having you on. You have been listening to THCB, watching THCB Gang. My guests today were Jen Goldsack from the now banning everything, but the book banning capital of the world in Florida. Kim Bellard from the calm Midwestern town of Cincinnati. JL Neptune from the island of Manhattan. Jen Benz from the either hellscape or emerging back into reality, depending on who you believe, city of San Francisco. And Robbie Pearl from United Airlines, somewhere between the East and the West Coast, going backwards and forwards. Our special guest, author of Uncaring, and from the Fixing Healthcare podcast. Definitely worth a listen. Thanks to everybody watching, listening on the podcast after the fact. We will be back next week with another THCB Gang. And until then, I'm going to say goodbye. It's Matthew Holt, your host, saying thanks for watching, thanks for listening, and I hope you enjoyed the conversation.